Hello everyone. This exercise is about improving diagnosis. And improving diagnosis means to improve diagnostic accuracy, efficiency, and logic. And in order to do that in this exercise, we're using two tools. The first one is a cognitive strategy, which is called Epilogical Approach, and it has 4 steps. The second thing is a scaffolding tool, which is mind maps. And there are various types of mind maps. There are all types of mind maps across the systems based upon patient presentations. And each patient presentation or patient chief complaint is going to have one single individualized mind map. So how do we put them together and how are they structured individually? So first of all, I would like to talk about the epilogical approach. Epilogical approach is a diagnostic strategy or a cognitive strategy in order to improve our diagnosis, and it can be applied in any situation, no matter what the patient's chief complaint or presentation is. It has 4 steps, and the way we use this is that we approach the patient by asking the first question, which is about the chief complaint. We clarify that complaint, make sure that we are on the same page as the patient. You can consider that as step number 0, because we just want to make sure that you're not misunderstanding patient's complaint. After you've clarified the complaint, for example, the patient may say, I have runny nose or a headache or chest pain or something. After you've clarified that, you use the first step of the epilogical approach, which is building probable diagnosis. And probable diagnoses are basically all the differential diagnoses that can be built around that chief complaint. For example, around the headache, we have about 20 plus different diagnoses that can be causing headaches. So you want to make sure that you recall from your memory all those diagnoses and make sure that you are at least consciously or subconsciously aware of all of them. And this requires a lot of medical knowledge. So if you don't have that data, at least look it up or make sure that you have memorized all of it. The second step, before you go to the second step, in the first step, you want to order all those differential diagnoses based upon epidemiology. So the common diagnosis should be on the forefront of your mind and the least common should be in the back of your mind. Then you move forward with the second step, which is recognizing urgent and emergent situations. So you want to make sure your patient in front of you is not crashing. For example, the patient is not in a dire situation where before you even finish the evaluation, and something is going to happen and the patient will crash. How do you recognize that situation? By looking at the patient's appearance, vital signs, and other red flag situations. So you want to make sure that the patient is stable and then you move forward. If the patient happens to be unstable or is in an urgent or emergent situation, then you first intervene and take actions to make sure you stabilize the patient and then move on to the next step. After the second step, which is going to be where the patient is stable, and more than 90% of the times the patients that are seeing you are going to be stable. After the second step, you go ahead and move on to the third step, which is weighing all the differential diagnoses or probable diagnoses. This is the most important step of the epilogical approach. This is what brings us closer to the diagnosis in an accurate way. So what does weighing mean? Weighing means that you evaluate all the diagnoses based upon your questioning and based upon the patient's answers, and then rule in and rule out all the diagnoses in a strategic way. So you don't leave any diagnosis behind. You make sure you address all the common diagnoses, and in order to do it in a very efficient way, you want to ask high yield questions first, and then you can go ahead and ask questions to rule out some of the uncommon causes of the problem. What does it mean to ask high yield questions, and how do we use the step of weighing in an efficient manner? Well, the first thing to do is just think about this step as a game of 20 questions. In that game, if you played it, we try to make sure that we ask questions that are going to separate large groups of entities broadly. So for example, if somebody says that I'm thinking of a person, the first question you ask is it a male or a female? So you've already kind of divided the population in 2 halves. Or you can ask if the patient is alive or dead, the person is alive or dead, or if the person lives in this part of the world or that part of the world. So those are the questions that kind of broadly divide groups of populations And that's kind of what we do. And so these questions become high yield questions because they are giving you a lot of information just to kind of narrow your differential diagnosis list. We use the same strategy when we are trying to do the differential diagnosis or weighing part of the epilogical approach. So you want to ask a good question that will basically rule out to some degree a big category of diagnosis and rule in to some degree another category of diagnosis. So for example, if somebody comes in and says, I have a headache, and you ask about the duration of the headache, then that gives you a really good piece of information, because you can now separate acute causes of headaches from chronic causes of headaches. Or if you ask about the location of headache and the patient says it's one side of the head, now you can easily divide the differentials into those headaches that are going to cause a problem in one side of the head versus the ones that are more generalized. So you can differentiate between migraines and tension headaches and stuff like that. So you want to ask those these are called high yield questions. The questions usually around duration, location, or any major eliciting symptom, which is going to divide the differentials into broad categories, is called the high yield questions. So after you've asked some good high yield questions, hopefully you will be able to narrow the list of differential diagnosis to the degree that now you have only a few out of 20, you have only maybe 4 or 5 diagnoses that you are considering. And then you can go ahead and move on to asking medium yield questions. Medium yield questions are the ones that are just going to help you support the diagnosis you are considering. So for example, if somebody is coming in with a headache and you've asked about location, duration, and a couple of other features, and the data you gather says that the patient has unilateral headache, lasted more than 4 hours but less than 3 days, and is associated with a pressure, throbbing, you start thinking about migraine, of course. And now you're going to support that diagnosis by asking additional medium yield questions, which are a little bit more specific to that particular diagnosis. In this case, it's going to be aura. You can ask the patient if they felt that the headache is coming on, or they smell a certain way, or they have other symptoms that kind of constitute aura. Those are the kind of the things that will help you determine if this information is supporting my diagnosis that I'm considering or not. So that those questions are going to be medium yield questions. So after the high yield questions, you ask the medium yield questions, support your diagnosis, come closer to the diagnosis, and then you move on to the 4th step of the epilogical approach. And the 4th step is called removing the anchor bias. What is anchor bias? Anchor bias is basically anchoring at a diagnosis prematurely. So closing your encounter, closing your diagnosis workup prematurely in such a way that you're ignoring important facts. So many of us fall victims to it. Anchor bias is a cognitive bias. There are more than 50 cognitive biases that occur. Doctors are prone to making all those mistakes and fall victim to at least 10 to 15 of those biases. And we want to make sure that we avoid those biases, because those are the ones that lead to errors. So the biggest of all of those is anchoring bias, or you can say the summary of all the biases is anchoring bias, because whenever you are falling victim to a bias, it means you are prematurely closing the encounter or your thought process, and you are anchoring at a place. So how do we remove anchor bias? Well, we want to make sure that we keep our thought process going, and we don't conclude prematurely. So in order to do that, what you want to do is you want to think about, okay, is my diagnosis correct? Did I ask all the questions that support my diagnosis? Is something not making sense? Are there things in this patient's presentation which point to a different diagnosis? Are there diagnoses around which I haven't even asked questions? For example, in a case with headache, if I've asked about migraine associated symptoms, well, those make sense, but did I ask anything about meningitis? Did I ask the patient if they have fever, they have altered mental status? Did I ask the patient about maybe stroke? Did I ask them about their blood pressure history? Did I ask them about recent personality change, if I want to rule out like an intracranial mass or tumor? So you want to make sure that you ask those pertinent questions that rule out the diagnosis that you haven't addressed yet. That is basically the method to use to remove anchor bias, because you want to briefly touch upon all those diagnoses that you were thinking that maybe are not likely, but still you don't want to completely ignore them. So briefly touch upon all of them. You don't have to ask every single question about every single diagnosis, but just ask one major question about about all of those diagnoses individually. And once you've done that, now you've come even closer to your diagnosis, your differential diagnosis you were considering. So you can go ahead and move forward with a physical exam. Make sure that your physical exam findings support your diagnosis, and if they don't, then go back and ask additional questions. Then you go ahead and do the lab testing and imaging and other things and diagnostic workup, and finally you come close to your final diagnosis. So that is what using the epilogical approach is. These are the 4 steps of the approach. Again, to summarize, the first step is to build a probable diagnosis list, which is all the differential diagnoses used to be on the forefront of your thought process, and preferably list them in the order of being more common to less common. The second step is to recognize urgent and emergent situations. If they are there, make sure you recognize and manage the patient accordingly, and don't let the patient crash. The third step is weighing, which is basically the art of asking questions in an efficient manner, and use the strategy of 20-question game. And then the fourth step is making sure that you remove any anchor bias and you don't fall victim to the biases, and then move forward with a physical exam, diagnostic testing, and improve your diagnosis skills. Thank you so much. There are about 50 mind maps which are around patients' chief complaints, and all of those mind maps have the epilogical approach mentioned briefly on the side, but then also the mind maps are designed in such a way that they are very intuitive, and easy to use in that sense. So the first thing on the top is going to be the patient's chief complaint. Then underneath that would be, or on the side would be, all the differential diagnoses that can cause that complaint or symptom. Typically those are in the black color, and then next to each differential diagnosis or the diagnosis is going to be the key symptoms that are associated with those diagnoses, and those are going to be in the green color. So those are the questions that are going to be your high yield and a mix of medium yield questions. So make sure you ask about all of those questions. The next thing on the mind maps would be something in the brown color, which is going to be the physical exam findings. So make sure you look at all of them. And the last thing is going to be purple color font, which is basically going to be your lab testing and imaging. These are also going to be specific to the differential diagnosis that is listed there. So they kind of go in a flow form. They can be looked at as schema, or the mind maps, or the flow charts, whatever you want to call them. But these become very handy when you are looking at a patient and you want to make sure you don't forget any diagnosis, you don't overlook anything, because improving diagnosis is the key to patient care, and we can drastically remove diagnostic errors if we use a good strategy and approach. Thank you so much.